Hello everyone, my name is Dr. Pranav and today I am going to teach you liver cirrhosis. So this will be just a basic video. I will teach you about the basic pathology that will be happening inside the liver. So let's start without any delay. So today's topic is liver cirrhosis. Starting from the basic structure of liver, what we have in liver. So as we know, basic structure of kidney, it's nephron. So like that we study the basic structure in the liver is hepatocytes. We call it hepatocytes or hepatocytes, which are the cells, or we can call it hepatic lobule, which is like a hexagon in shape. So starting from the center, in center we have the central vein, then we have the cords like structure. Cord like means it is attached in the form of string. So these are the cords of hepatocyte cells. Then adjacent to it we have the sinusoids or the blood vessels. That means the blood vessels that are entering into the hepatic lobule. Then to the sinusoids, the walls of the sinusoids, that means the here near the wall we have the macrophages. These are the special type of cells which are present in liver, which are macrophages, and in liver these macrophages are called as Kupffer cells, which are present on the walls. Okay, done. Now we have this portal triad. Why it is called portal triad? Portal means whatever things that are coming inside the liver is called portal, and triad means it consists of three things. What three things we have? We have first the portal vein, the hepatic artery, as well as the bile duct. These are the portal triad which is present in the edges of the hepatic lobule. Then there is a space of Dissay which is present in between the sinusoids as well as the cords of hepatocytes. So this is very important. Why? Because the space of Dissay is present between the hepatocytes and sinusoids, as I told. Then the itocells, we like in this space of Dissay we have two types of cells. First is itocells and second is stellate cells. Why? So the stellate cells have the function of vitamin A storage, and stellate cells, these are the important cells because they help in collagen formation. And which type of collagen? It is basically collagen type 1 and type 3. This is a very important question which can be asked in the exams. So this is the type of collagen we see, which is formed by the stellate cells. And also the one important thing, amyloid deposition takes place in this space of Dissay. Next we have canal of Herring, which is present in between the hepatocytes and cholangiocytes. What are cholangiocytes? Cholangiocytes are basically the bile duct cells. So this canal of Herring is present between hepatocytes and cholangiocytes, which contains the ovals or the stem cells, which are basically needed for regeneration. Like in case of there is liver damage or any case of trauma, so these oval or stem cells help for the regeneration of the liver cells or the tissues. So coming to the next, we have the Kupffer cells. Kupffer cells are called the macrophages in the liver, which are present in the walls of sinusoids. So we have done this. Now what happens in our liver? Starting, I will tell you about the basic of bilirubin metabolism. What happens? So as we know, RBC, the normal lifespan of RBC is 120 days, and after that 120 days it goes to the spleen, and where the destruction of RBC happens. Then RBCs break down basically into heme as well as globin. So today we will discuss only about heme because heme is important for our today's topic. So heme is converted into biliverdin in the presence of heme oxygenase enzyme. This biliverdin is further reduced in the with the help of enzyme called biliverdin reductase into bilirubin. So heme is converted into bilirubin and biliverdin, and biliverdin is converted into bilirubin. Now this bilirubin which is formed is unconjugated, or we can say indirect. Why? Because it is insoluble. So our body cannot be absorb this bilirubin and it's of no use. So what happens is this bilirubin, with the help of albumin act as a transporter. So albumin takes this bilirubin into the liver, and so in this liver the bilirubin which is unconjugated is converted to conjugated bilirubin with the help of enzyme called UDP glucuronyl transferase enzyme. What this enzyme does, it converts the bilirubin which is indirect, unconjugated or insoluble into conjugated bilirubin which is soluble. So a body can be used this soluble bilirubin. Now this bilirubin comes out of the liver with the help of gate. We can call it a gate or simply like an opener. This opener is called MRP2 and ATP family, the name of this gate. So this conjugated bilirubin has three fate. That means when it comes out of the body, this from the liver, so this bilirubin has three functions. First, some part of the bilirubin goes back to the liver, which is called enterohepatic recirculation, while second, some part of the bilirubin goes to the urine, which is called urobilinogen, and some part of bilirubin goes back to the stool, which is called stercobilinogen. So that's why our urine is yellow in color and our stool is in brownish in color. So this characteristic feature or characteristic color to our urine as well as stool is given by bilirubin. Yeah, that's all about the bilirubin metabolism. Now we will be talking about hyperbilirubinemia. What is hyperbilirubinemia? Hyper, that means we can see elevated levels of what? Bilirubin. So hyperbilirubinemia means increased level of bilirubin in our body. But these are of two types. First is unconjugated and second is conjugated. So unconjugated, we will talk about this first. So in hyperbilirubinemia, we can call it as another name, which is a very famous name of the disease, which is jaundice. What happens is, how can we diagnose the patient? Just by visual examination, we can check the patient's skin, sclera, the mucous membrane of the patient. Why just we check the patient's skin or the sclera of the eye or the mucous membrane? Because the skin, sclera or the mucous membrane has elastic fibers in it. What the bilirubin does, this bilirubin has more affinity for the elastic fibers. So what it does, when the bilirubin level increases, when it goes to the skin, so it has higher affinity to bind to elastic fibers. So what will happen? Elastic fibers will become yellowish in color because there is more bilirubin binding to it. That's why these three locations are main. That means we should check the skin, the sclera and the mucous membrane of the patient. This is just the basic. So without any delay, starting from the unconjugated hyperbilirubinemia, what is meant by that? That means hyperbilirubinemia means elevated level of bilirubin, but which? Unconjugated. The one that we see here, this bilirubin, that is unconjugated one. So this unconjugated bilirubin is increased in our body, which is due to various reasons. First reason is due to hemolytic anemia. This is a kind of disease where there is RBC destruction takes place. So what happens is, in hemolytic anemia, like in case if there is any abnormality, like there is abnormal destruction or excessive destruction of RBC, then what happens? If more RBCs are destroyed, that means more RBC breakdown, that means more hemoglobin will be produced. So more hemoglobin means more bilirubin, and the bilirubin level increases and it gets stored in our liver. So the bilirubin level gets increased, which is called hyperbilirubinemia of unconjugated one. So first is hemolytic anemia, excessive breakdown of RBC, due to which the unconjugated bilirubin level rises. Second is a syndrome called Crigler-Najjar syndrome. What happens in this? It is of two types, type 1 and type 2. What happens is, type 1 means complete deficiency of UGT. What is UGT? I told you before in the bilirubin metabolism. This one, UGT. UDP glucuronide transferase enzyme. What happens in type 1 is there is complete deficiency of this enzyme. So what will happen when there is complete deficiency? Because of this complete deficiency, the unconjugated bilirubin will not get converted into conjugated bilirubin. So there will be accumulation of this unconjugated bilirubin. What will happen? The patient will may get sick, and in severe cases he may die. So this is 100% fatal. That means there are 100% chances that patient will die for sure. Next is type 2. What happens in type 2 is there is partial deficiency, like sometimes the enzyme may not work properly, not fully function. That's why it is called partial deficiency, not fully deficiency. In type 1 there is complete absence of UGT enzyme, but in type 2 there is partial deficiency of UGT, which can be treatable by, we can give phenobarbital drug, not the drug that you are thinking, but this medicinal drug, phenobarbital. So we can give this phenobarbital. What it does is it increases the activity of UGT enzyme. So what happens in type 2? There is partial deficiency, we give phenobarbital, so activity of UGT increases, that means it becomes normal. So normally the unconjugated bilirubin will convert it into conjugated bilirubin, simple as that. So type 2 is treatable, but type 1, which is 100% fatal, the patient may die. Next is also a syndrome called Gilbert syndrome. What happens is, this is also same like Crigler-Najjar syndrome. So Gilbert syndrome is very mild deficiency of UGT. There is like little bit deficiency of UGT, but the main point to remember is the patient are asymptomatic. That means the patient will show no symptoms. This is very important to know in Gilbert syndrome, that patients will be asymptomatic. Okay, done. Next is conjugated bilirubinemia. Before I talk about unconjugated, now I'll be talking about conjugated, like why the conjugated bilirubin level rises in our body. First, it can be due to obstruction. Obstruction, like there can be any clonorchis or opisthorchis. What are these? You studied basic 11th and 12th science, and that we have been told that these are types of liver fluke. You know, various kinds of liver fluke, sheep flukes, like that. So this can be the conjugated bilirubin level can be rises. First reason is due to obstruction. Why? In obstruction, there is first it can be due to clonorchis or opisthorchis. Next is due to cancer. Strictures. Strictures means narrowing of the vessels. Like there can be obstruction like to the passage of the bilirubin through the bile duct, like that. So this can be due to strictures, that is narrowing or stenosis. And fourth is stones. It can be anything. It can be bile duct like stones, etc. So first it can be due to obstruction, which is due to clonorchis or opisthorchis, cancer, stricture, and stones. Next is it can be due to biliary disease. So biliary disease can also lead to increase in the bilirubin amount. Done. Then there is Dubin-Johnson syndrome. What happens in Dubin-Johnson syndrome is our liver metabolizes various types of enzymes, various types of metabolic products. So in this Dubin-Johnson syndrome happens, our color of the liver get dark, like dark pigmented liver is seen in Dubin-Johnson syndrome. This is a characteristic feature which you should be remembering for your exams. So why? Many of you can ask, like this dark pigment liver can be due to bilirubin. No, this is no. Why? Because this dark color pigment liver is due to epinephrine. Because epinephrine is in the liver there is metabolism of adrenaline. As a byproduct we get epinephrine. What happens is sometimes epinephrine byproducts can accumulate in the liver. Maybe there can be a liver obstruction, they can't go outside, so there will be accumulation of these metabolites of the epinephrine. Due to this, the epinephrine gets accumulated in the liver and our liver color becomes dark. So next is Rotor syndrome. What happens in Rotor syndrome is there will be a defect in organic anion transporter, that is OATP. What is OATP? I told you before. Like there will be a gate, this the gate. We can see like there will be defect in this gate. That means there will be no opening, that can be obstruction. Why? Because of this, the defect in this OATP, we can call it ATP family or OATP. It's similar, don't worry about that. So what happens is in Rotor syndrome there will be defect. What will happen? In this case there will be bile obstruction, because of which the bile will not come outside of the liver. So there will be non-pigmented liver which can be seen. So first we see in Dubin-Johnson there will be dark pigment liver, which is a characteristic feature, and in Rotor syndrome there is non-pigmented liver, which is also a characteristic feature of this disease. So our next topic is main topic. Coming to the main topic, we have liver cirrhosis. What happens in liver cirrhosis? So we can see there can be a damage to the liver parenchyma, or it can be a trauma. So what happens in cirrhosis is there will be damage to the liver parenchyma, then there will be bridging of fibrous septa. What does it mean? So we can see here, this is a liver, normal liver. What happens is there will be damage to the liver. Then what the collagen fiber do in our body? How the collagen fibers are formed? I told you before that these are formed by the stellate cells, which are present in the space of Dissay. So this stellate cells helps in collagen formation. This collagen comes here, and what it does is it forms like a fibers in the damaged area, like where the liver is damaged, it forms a fibrous septa. What happens is later on this bridging occurs. Bridging means joining. So like some fibers are here, some are here, some are here, like this, and later on there will be a bridging of this fibrous septa. This is the second stage of liver cirrhosis, or like we can say development of cirrhosis. First, as I told, there will be damage. Second, there will be bridging of the fibrous septa. And which type of collagen? Collagen 1 and 3. Type 1 and type 3 collagen will be there. And third, there will be regeneration of parenchymal nodules. Simple. There will be damage to the liver. There will be collagen accumulation. The collagen will try to repair the liver. There will be fibrous septa formation, the bridging of it, and regeneration nodules. We can see these small nodules. These are called regeneration nodules. These are basics of cirrhosis. Next is features of this cirrhosis. What happens? So in cirrhosis there will be affect like damage to the liver. So what will happen? There will be overall decrease in the synthesis. I have written here. There will be decrease in synthesis of everything, whatever, like enzyme, vitamins and all. So first there will be decrease in synthesis. Next there will be decrease in the protein. Which protein? Albumin protein. So due to this decrease in albumin protein, there is a ratio that is albumin globulin ratio, which also decreases. Same, if albumin level goes down, then globulin level also goes down. As simple as that. Next, what happens is there will be like due to deficiency of albumin or absence of albumin, the patient will present with edema, or we can call it swelling. So due to decrease in albumin in the body, we can see the patient coming into our OT with present with edema. Next is a decrease in clotting factor. What happens as liver produces many types of clotting factors. So liver is damaged in the case of cirrhosis. So there will be decrease in clotting factor. That means if there are no clotting factors or there are less clotting factors, so what will happen? If there is kind of bleeding in a body of the patient, there will be bleeding manifestation. That means there is decreased clotting factor, so there will be less clotting, or it will take more time to clot, so there will be more amount of bleeding. This is what we can see, bleeding manifestations in the liver cirrhosis cases. Next, but the important thing to remember, our liver metabolizes ammonia as a byproduct into urea. So normally the ammonia is converted into urea in the liver. So what will happen when there is damage to the liver? There will be increased amount of ammonia in our body. That means ammonia toxicity will occur. Toxicity means accumulation, and it will get toxic, it will produce toxics, so which is called ammonium toxicity. What happens is this ammonia can cross the blood-brain barrier. Suppose this is our brain. So this brain is covered by an outer barrier which is called blood-brain barrier. It protects us from various things. It like virus will not enter. It protects around like certain drug toxicity, so which is protective measure for us. But this ammonia can cross the blood-brain barrier and cause hepatic encephalopathy. The patient may suffer from hepatic encephalopathy. What is meant by hepatic encephalopathy? Hepatic means something coming from the liver. Where to? Encephalo means brain. Pathy means the disease. So the disease occurring to the brain from the liver is called hepatic encephalopathy. In detail you will study more in pathology. And the other symptom is asterexis or the flapping tremors. Like we can see we have to tell the patient to raise their hands, and we have to push their hands back. So normally what will happen? If we push their hand back, so normally it comes to normal. But in case of asterexis or flapping tremors, if we push their hands back, it will come like this, like it will tremor. This is called flapping tremors. These are two characteristic features we can see in hepatic encephalopathy, which is due to increased amount of ammonium in our body. Next is increase in estrogen. Our liver metabolizes estrogen as well. So when there will be damage, there will be increased amount of estrogen in body. What will it do? It will cause palmar erythema. That means the palms of a hand will occur reddish. Why? Because there will be more blood coming to the area, palms and soles as well as that. So that's why there will be palmar erythema. Next is spider angioma in blood vessels. That means we can see like this spider-like structure is formed. We can see on our body. This is spider angioma in blood vessels. Like spider-like shape it gives. Angioma means the blood vessels, which is Latin term. Next is gynecomastia in males. As we know, increased estrogen may cause breast development in males, so it can occur gynecomastia in the males. And testicular atrophy. We know that for development of testicles, estrogen is not important, but testosterone is very important. So what happens is when there is an increase in estrogen, there will be testicular atrophy. Atrophy means decrease in the size or decrease in the like developmental stages. So there will be testicular atrophy due to increase in estrogen. Now coming to the last part of cirrhosis, what happens? Like if there are any complications, if the patient not coming to us, if he just trying to take home remedies and it not get treated without any kind of drugs, so this will lead to complications of the cirrhosis. What will happen? Due to cirrhosis, there will be increase in the resistance of portal circulation. What is meant by portal circulation? Portal circulation means the circulation, the blood supply coming towards the liver and going out of the liver. This is called portal circulation. What will happen due to cirrhosis? As I told, there will be fibrous septa coming, there will be bridging of this. So what will happen? It may cause obstruction in the circulation. What will happen in obstruction? There will be increase in the blood pressure, like blood supply, blood flow will be increased, which will cause increase in the portal circulation pressure, which will cause portal hypertension. Simple as that. Portal hypertension means there will be increase in the blood flow, increase in BP, where in the portal, like in the liver. So this portal hypertension will occur, which will cause 5 symptoms, or we can say it affects mainly 5 types. What are these types? First, it can go to the spleen, like the blood supply may go to spleen, excessive blood, and it may cause congestive splenomegaly. Second is hemorrhoids. Our blood vessels are connected to the GIT, so from there the GIT through the stomach to the intestine, it can go to anal canal, where there it can form hemorrhoids. Next is ascites. Ascites means fluid retention in our stomach. There will be fluid accumulation in our stomach. So when we try to percuss the abdomen, we can feel a dumb sound, or like fluid accumulates in the stomach. Next is shunt. Shunt can also occur, but main important is esophageal varices. What happens is the lower part, like this is our esophagus and this is our stomach. So what happens here in the lower third part, 1/3 part of the esophagus, there will be dilation of the veins which are present in the esophagus. So what will happen? There will be dilation of the veins and it will cause obstruction in the esophagus, but this is due to complications. So what will happen if these esophageal varices are not treated? The veins will try to accumulate more blood, there will be more dilation, and at last there will be rupture of these blood vessels, and due to this there will be more bleeding, non-stop bleeding. Patient can't eat anything. Maybe this esophageal varices, the complications can lead to the death of the patient for sure. So coming to the last part of our lesson, that is liver cirrhosis treatment. What we do in treatment, how we can treat. Unfortunately, liver cirrhosis is irreversible. In the definition, we say liver cirrhosis is irreversible scarring of the liver tissue. Scarring means what happens if you got somewhere injured, so after some time the place get heals, but it leaves a scar like mark. So this is the scarring of liver tissue. While you can't reverse the liver cirrhosis, but the treatment focuses on some main points, like liver cirrhosis is irreversible. So what we can do? We can just delay the procedure of liver cirrhosis so that the patient may live long. How we can do this? By so this treatment focuses on mainly 4 types. What is do? We can do the slow progression. That means we can give the drugs to the patient so that the liver cirrhosis stages may occur like slight delayed, like so slow progression of the cirrhosis, which will help the patient to survive more. Second is managing the complications so that the liver cirrhosis may not develop some complications. As I told, it may develop into portal hypertension, it may cause splenomegaly, ascites, or esophageal varices. So managing the complications is another step. Next is preventing further liver damage. How we can do this liver damage? Like how can we prevent it? So for that we should prevent the further liver damage. We should tell the patient not to consume alcohol, to take a good amount of balanced diet, etc., etc. Next is last, preparing for liver transplantation if needed. What happens is liver cirrhosis is very dangerous, as we know. So there will be complications to this, and at the end stage, that means at the end, the liver cirrhosis can convert into like fatal. The patient will die. He may develop severe symptoms. So what we can do in severe cases, In severe cases, we can advise the patient for the liver transplantation. So preparing for liver transplantation if needed. Next is alcoholic cirrhosis. This is a type of cirrhosis. So what we can do, complete abstinence. That means complete absence of alcohol. We should tell the person not to consume alcohol because your liver is already damaged. If you consume alcohol, more it will get damaged, you may die. So not like we have to tell the patient like this that you may die, but we should tell the patient that you should not consume alcohol anymore, otherwise it may cause you death. And nutrition support, taking balanced diet is very important. Next is hepatitis B or C. In this case also liver cirrhosis occurs. Like in hepatitis B or C, liver cirrhosis may occur. So in this case we can give antiviral therapy to the patient. Example, in this antiviral therapy we have a main drug called tenofovir. We can give this antiviral therapy to the patient, which may delay the cirrhosis. Next is autoimmune hepatitis. What happens is it is due to the hypersensitivity reaction, or when the immune system of the patient gets hyperactive, which causes autoimmune hepatitis. In this we give a combination of drugs, that is corticosteroids plus azathioprine. This combination is given in autoimmune hepatitis. Next is Wilson's disease. What is basically Wilson's disease? We can also call it copper overload. Copper overload. That means there will be copper accumulation. So in detail you will study more in pathology. There will be KF ring that can occur in the sclera of the Descemet membrane of the sclera of the eye. So in this Wilson's disease, there will be copper overload in our body. What we can do? We can give chelating agents like penicillamine and zinc. These two agents we can give and we can cure the Wilson's disease. Why I am telling you this alcoholic cirrhosis, hepatitis B, C, or autoimmune hepatitis, Wilson's disease, and last is liver transplantation. Why I am telling you this? Because these all 5 diseases are the complications to the liver cirrhosis. So basically in these 5 diseases we can see liver cirrhosis. Last is liver transplantation. As I told you before, in severe cases where there is no option to save the patient, we have to do liver transplantation, and which is the only curative treatment for the end stage of cirrhosis. So this is just a basic of liver cirrhosis. In detail you will study more in pathology subject. I hope you enjoyed this video. Thank you so much for watching this video till end. So if you want this notes, I can give the PDF form in the description, so you can check it out.